right? So erythropoietic porphyrias here, it's because of enzyme deficiency which occurs on bone marrow. Okay, and here hepatic porphyrias is because of enzyme deficiency occurs on liver. So when the liver has an enzyme deficiency, so it's a hepatic porphyrias. When the enzyme is deficient in bone marrow, so it's a erythropoietic porphyrias. So this is a classification of porphyrias, or disorders of porphyrin metabolism based on tissue involved, or we can say the organ of accumulation of the some metabolic product. So, okay, so if the organs is involved with the bone marrow, so we call it as erythropoietic porphyrias, and when the liver is involved, so we call it as a hepatic porphyrias. Okay. uh, Already discussed in the morning this thing, like this is the what the steps we have studied, steps which makes heme production in our bone marrow. So it start from succinyl coenzyme A plus glycine that gives us delta amino levulinic acid, and through subsequent reaction and different enzyme, we finally produces heme as a end product. Okay, and deficiency. One of you can mute yourself. Can you mute yourself? Your voice is coming from background. Please mute yourself. So enzyme deficiency is this. These are the different enzymes which catalyze a particular reaction. You can see. So enzyme deficiency in results in different types of porphyria. You can see the delta ALA dehydratase porphyria, acute intermittent porphyria, or there are erythropoietic porphyria. There are different types of porphyria are there, which are based on the deficiency of particular enzyme in the heme biosynthesis. We already discussed it. Let's know about this one on disorders of porphyria here, which is based on the classification that we are going to study. It's based on inheritance. Okay, so it can be primary inheritance, or it can be a secondary type, which is called acquired. Okay, so there are two types of porphyria is there. Either it is called as a primary, or the second is called secondary. So primary porphyria is inherited type, and secondary porphyria is acquired type, right? So what is primary porphyrias? So here primary porphyria is a hereditary enzyme defect, right? And this hereditary enzyme defect is a by birth defect, where now first we are going to know is hepatic porphyrias in which is of hereditary type. So here acute hepatic porphyrias, where there is acute intermittent porphyrias, autosomal dominant like hereditary disorder is there, where porphyria variegata is another type of hepatic porphyrias. This is also of autosomal dominant type. And hereditary coproporphyria, this is also of autosomal dominant type. And DOS porphyria is autosomal recessive type. Now, and second one is a chronic hepatic porphyrias, which is chronic, and this is also hereditary type. So here, Porphyria cutaneous tarda, which is autosomal as well as autosomal dominant, or we can say it can be the acquired type also. Hepatoerythropoietic porphyria, this is of autosomal recessive type of hereditary disorder. The second, which is that we here we studied the hepatic porphyrias, where the hepatic tissue is involved, where there is accumulation of some metabolic product, and there are different types, acute and chronic. We have understand this. Now coming to the next, which are erythropoietic porphyrias. So here there is a congenital erythropoietic porphyria. For example, Gunther disease, which is an autosomal recessive type of disorder. Erythropoietic protophyria, which is autosomal dominant. So we studied here both types of porphyrias. It's hepatic and erythropoietic under the primary porphyria, where the defect lies is because of hereditary enzyme defect. Okay. Now secondary porphyria, where this is explained as an acquired type of porphyria, and here, for example, secondary coproporphyria caused by intoxication, hepatic disease, blood disorder, and infection and starvation. So these are different causes that may leads to development of coproporphyria, and these are what it's not a genetic defect actually. Okay, there is a toxins, or there is a hepatic disease, or there is a blood disorders, or there is infection, or there may be the starvation. These may leads to the development of porphyria called as a coproporphyria. Secondary protoporphyrinemia. So protoporphyrinemia is another disorder where it's a type of acquired type of disorder, and this is caused by when there is anemia, when there is alcohol or chronic heavy metal poisoning, okay, or when there is a metal toxicity. Okay, so metal toxicity such as what we say heavy metal basically toxicity, or when there is alcohol poisoning, or when there is anemia, so this protoporphyrinemia may develop, right? Now we are going to study a very specific type of porphyria, also known as Porphyria cutanea tarda, PCT. Here we are going to know the epidemiology of this. This is most common porphyria, right? Most common, and peak incidence occurs when the person is between 40 to 70 years of age. And here we can say the female, male and female ratio. We can see the male, actually the male is more prevalent. This means this PCT, Porphyria cutanea tarda, is more prevalent in male than the female. Okay? This is the symbol of male, this is the symbol of female. So male suffer more in compared to the female. Now etiology means what is the causes of this PCT. Okay, defective uroporphyrinogen third decarboxylase, also known as UROD. URO means uroporphyrinogen third, and D is a decarboxylase. In short, we say erode. Okay, so there is a defective enzyme, erode defective, and the type 1 type is acquired insufficiency of erode in the context of hepatic damage, right? So this erode type 1 can be the acquired insufficiency of erode, means the erode, which is the enzyme which is not sufficient, not in appropriate amount because of hepatic damage. So type 1 is because of the hepatic damage, which leads to insufficient amount of uroporphyrinogen third decarboxylase in our in our liver. Mainly occurs in older men. Okay, this is the prevalence of this type of porphyria. So older men suffers more, and who are also having the additional habits of chronic alcoholism and also hepatic cirrhosis. So chronic alcoholism and hepatic cirrhosis. So patient with this both disorder, and at the age of the older age, so usually they usually suffer from this type of enzyme defect. Type second is an inherited one. Okay, type 1 is acquired, and type second is inherited, which is familial, which is transferred from one generation to other generation. And this is a specific type of inherited disorder, which is autosomal dominant type of disorder. Okay, so the enzyme is defected. The enzyme which produces erode is defected. Okay, the gene is defected, and because of that, by birth there is a problem. I hope there is no problem with etiology. Yeah, you will have understand how does this PCT PCT, that is a Porphyria cutanea tarda. Porphyria cutanea tarda, how it occurs, what is the causes. So we have studied the two causes. Type 1 is acquired type of causes, and type second is inherited type of the the defect. So acquired defect is because of the hepatic damage. Inherited is because of some familial or the defect in the gene which produces erode. Now susceptibility factors. What is susceptibility factors? Here increased hepatic iron stores or hemochromatosis. So this can leads to the development of PCT. Alcohol or smoking, hepatitis C, HIV, estrogen therapy. So these are the high risk factor. Okay, so person who have this condition in the body, so usually they have a porphyria. Uh, what do we say? PCT is a porphyria cutanea tarda. Okay, so porphyria cutanea tarda usually occurs in a person who has increased hepatic iron stored, or hemochromatosis, or what we say alcohol, what is smoking, or habits, and hepatitis C and HIV infection, or if there is estrogen therapy. So this group of person usually are more susceptible to the infection. Now, pathophysiology, that how this develops, what is the mechanism? So we have understood that that when there is a defect in this particular enzyme urode, okay, so defect in this enzyme leads to uroporphyrin accumulation in the skin. This compound is accumulated in the skin, and because of this, sunlight dependent skin damage occurs. Okay, when there is a defect, when there is a defect in this enzyme, because of that, this compound is accumulated in the skin or tissues, and when the person is exposed to sunlight, so it causes damage to the skin. So we can say it's a chronic photosensitivity. Next, clinical findings. So cutaneous manifestation can occur, the skin disease or skin deformities takes place. For example, increased fragility of sun-exposed skin leads to development of blistering and impaired healing. So we call it as a blistering photosensitivity. So blisters are usually developed, or there is an impaired healing of the some wound. Next, healing results in scarring and milia formation. So there is a skin, there is a scar-like formation, there is a milia-like formation on the skin, and so it's a rashes, kind of rashes. Okay, so which appears because of the skin damage to the skin. Hypertrichosis. So hypertrichosis may occur. Hyperpigmentation may occur. Scleroderma like changes, especially forehead and scalp. So forehead and scalp region, there may be the changes in the skin, and that is called as scleroderma. Commonly occurs on like usually dorsum of the hand, so dorsum area of the hand, face and neck, extensor surface of the forearm, and the diagnosis very important. How can you diagnose this? The diagnosis is basically based on urinary test, right? So it's increases uroporphyrinogen. Okay, so we can see that when the uroporphyrin is present in the urine, so the color of the urine become tea color urine, right? So this is the criteria that we can do the physical examination of urine, and if the color of the urine become tea color, so we have to understand that there is an increased uroporphyrin in the urine. Blood test we can do, which will give us a result of outcome of increased porphyrins in the blood, and also possibly abnormal LFTs can be seen. So LFT is a liver function test. When the patient goes for LFT test, so the test values are abnormal. What therapies are available? So we can avoid susceptibility factors. Okay, whatever the factors we have studied, which increases the susceptibility, like alcohol, okay, smoking, estrogen therapy. These are the factors which can increase the susceptibility. So we need to avoid this, and also we need to avoid exposure to the sunlight. Okay, phlebotomy, hydroxychloroquine or chloroquine. These are the drugs. So these are the drugs we can take. And now we are going to study acute intermittent porphyria. This is the second types of porphyria, where we need to know that uh, there is a epidemiology, means the study on the population about this acute intermittent porphyria. This acute intermittent porphyria here must the second most common porphyria, which is what is available in the entire universe. So the second most common porphyria is acute intermittent porphyria, and the peak incidence usually occurs when the patient are approximately 30 years of age. So here this porphyria may develop, and here we can say female are more susceptible, or this disease is more prevalent in the female than the male. It's approximately the ratio is 2 is to 1 of female is to male. Okay, so in female it is found large amount. What is the causes of this acute intermittent porphyria? Acute intermittent porphyria is an autosomal dominant disorder, the genetic disorder, and here mutation of porphobilinogen deaminase is a PBGD, is a short form of this enzyme, previously known as a uroporphyrinogen first synthase, which is located on the chromosome 11. The gene is located on the chromosome number 11, and where the gene is defected, and because of that, the mutation in the gene leads to defective porphyrin deaminase production. So this enzyme is produced abnormally in our blood, in our body. So many patients with enzymatic defect associated with the acute intermittent porphyria remain asymptomatic unless an attack is triggered. So usually the symptoms are not seen in the patient. So we call it a asymptomatic, asymptomatic symptoms. But symptoms can be seen when there is a attack is occurred, when there is a severe condition. So the symptoms may start to see. Attacks are triggered by what can trigger the attacks. So certain drugs, especially inducer of hepatic cytochrome protein. Okay, cytochrome protein hepatic inducers leads to this acute intermittent porphyria. Here, several enzymes involved in heme biosynthesis, as we know. Several enzymes are involved in the synthesis of heme, and are the cytochrome protein enzymes of cytochrome P450. So this is the cytochrome molecules which contain iron molecule, porphyrin molecules. Okay, and these molecules, enzymes, basically are involved in the heme synthesis. Okay, so inducer of this cytochrome protein enzyme stimulate heme biosynthesis, result in accumulation of porphyrin intermediates. So this certain drug stimulates cytochrome protein enzymes, and which will further stimulate heme biosynthesis, and further as a result of stimulation of heme biosynthesis, there is accumulation of porphyrin intermediate in the our body. So certain drugs can stimulate the production of porphyrin intermediate, and it may can uh, trigger the attacks on the patient. Similarly, anticonvulsant, especially barbiturate, uh, benzodiazepine, and phenytoin, these are the anticonvulsant drugs. When the patient takes it, so the attacks are triggered. Sulfonamides, so these are the drugs. Anesthetics, these are the kind of medication. Hormone therapy, so these what we understood, these are the factors which can trigger the attacks. Okay, alcohol, smoking, sex hormones, testosterone, basically, and fasting also can trigger the attack. Increased intake of carbohydrate may alleviate symptoms. So here, when we take the carbohydrate, the symptoms can be normalized. Stress can also trigger the attack. Now, pathophysiology, that how this acute intermittent porphyria occurs. Defective porphobilinogen D type, leads to this enzyme defect leads to accumulation of porphobilinogen and delta aminolevulinic acid, and after that, when this is accumulated in the body, so the symptoms start to be you can see the symptoms in the patient. Now, clinical feature you can see here, fever can be seen in the patient. GI symptoms, gastrointestinal symptoms, where severe abdominal pain, nausea, and vomiting, where these are the symptoms related to the gastrointestinal symptoms. Neurological abnormalities are there, where we can see polyneuropathy, for example, non-specific pain. We don't know where is the actually pain and why the pain is. Weakness, patient will have a weakness, patient will have a fatigue. There is a paresthesia is a something burning or prickling sensation that is usually felt on the hand, arm, legs and feet. So burning and prickling sensation occurs. This is called as paresthesia. Paresthesis is a condition of muscular weakness caused by nerve damage or disease. So paresthesis can also occur, which is a muscular weakness actually, and this can be a result of nerve damage. Seizure also uh, clinical feature signs, and it's a sudden or uncontrolled electrical disturbance in brain. Okay, so there is a electrical disturbance in the brain. Okay, and if it is sudden, so it can cause in changes in behavior, movement of feelings. So changes in the behavior, changes in the movement, changes in the feelings. Or even it can causes the consciousness, changes in the level of consciousness. So this is the seizure actually. Okay, so seizure can occur when there is acute intermittent porphyria. Another is a psychiatric abnormality like hallucination, which means it's a kind of sensation that appear to be real but are created within the mind. So this is a kind of symptoms. Okay, psychiatric abnormalities. Okay, which can be seen in the acute intermittent porphyria. Examples include seeing things that are not there. Okay, the patient must can see the things, but actually they are not really um, what other person can see. So seeing or hearing voice or other sound, experiencing body sensation like crawling, feeling in the skin, smelling odor that are not there. So this is a hallucination, which is a psychiatric abnormalities. Okay, so disorientation can also occur where it's a state of mental confusion. So when there is a mental confusion, we call it as a disorientation, and this can also be seen in the acute intermittent porphyria. Next is anxiety, which means a feeling of fear or worry that interferes with one's daily activities. Okay, so feeling of fear or worry can occur, and it can affect the daily activities what the patient actually do. And for example, the first day of school, when the person go to the first day at the school, or when first time going to the job, basically job interview or giving a speech may cause most people to feel fearful or nervousness. So that is a what we call it as anxiety. Insomnia is a sleep disorder. Okay, so this kind of psychiatric abnormalities may occur when the patient have a intermittent acute intermittent porphyria. uh, Hyperactive autonomic nervous system with increased catecholamine levels. Here, autonomic dysfunction may occur, which leads to tachycardia, that is increased heart rate, okay, and hypertension, okay, that is increased blood pressure. So this may occur because of hyperactive autonomic nervous system. So autonomic nervous system become hyperactive, and because of that, it increases the level of catecholamine, and further it causes tachycardia and hypertension, and what we call as the autonomic dysfunction. Red purple urine. So urine color is what we can see from the outside. When the patient urinate, we can see the color of the urine become purple or more prominent uh, uh, in the color when the patient is exposed to the sun or oxygen. Okay, so when the urine is exposed to the sun or oxygen, so the urine color change from red to purple color urine. The skin is actually not involved in acute intermediate porphyria. So here, this is the what we have to understand. Okay, here skin is not involved, but what we understand the PCT, in PCT disease, the skin is involved. How can we diagnose this acute intermittent porphyria? So here the urine test is again done, which especially during attacks we can do, and we can see the level of PVG and yearly. This is a delta amino levulinic acid. This is porphyrin. So both of the biomolecules are increased in the urine, and urine may turn brown or dark red or purple when exposed to sunlight. So this is the diagnostic outcome. The reports the patient usually suffers when there is a acute intermittent porphyria. So now we have completed about we have learned two special type of porphyrias, and here we completed we have completed this porphyria cutaneous tarda we have completed, and we have completed acute intermittent porphyria here. And if you have any confusion, you can ask me the questions. Yes, CAF. CAF is